All right, folks. Dual screen. This is the PT on Ice morning show. So excited to join you guys today. My name is Paul Kaloran. Sweet, we got some joiners. Instagram, YouTube. Gotta admit, I'm a huge fan of the PT on Ice daily show. Also, would like to admit, rarely am I watching it 6 a.m. Pacific time, West Coast. So the eyes are still opening. The coffee is still warm here in Washington. But thanks for joining. If you haven't seen some of the more recent announcements, like I said, my name is Dr. Paul Kaloran. I'm part of the team that is spearheading. We're launching this dry needling division for ICE and could not be more excited for the product we're creating. It's going to be unlike any dry needling course or dry needling education program out there. We're building a rock star faculty and we're kicking off soon. Initially, the plan was let's start hot and heavy 2023. But then we got a few courses. The very first people who will be on our courses will be coming October, November, December this year. So my first time being on, I've done virtual ice, but I haven't done the PT on ice. The topic today the headline is dry needling doesn't have to suck. That's the bumper sticker. And if that's kind of a hard challenge, if that's a little angsty for you, let me unpack it a little bit. First of all, dry needling doesn't have to suck kind of first acknowledges, and I think we have to acknowledge, that sometimes dry needling can suck. And really, honestly, this is not a challenge to any single clinician or methodology or educational institution out there. If anything, this is a hardcore reflection in seeing how I used to treat and how I used to approach and even offer dry needling as an option to my patients, and how that has changed over 10 years. So when I say dry needling doesn't have to suck, what I want to unpack today is equal parts kind of pain science, the words we use to introduce it and really how we present it to a patient, the dry needling approach. And full truth there is that with more dry needling experience comes the confidence, the expertise, kind of that expert touch of needling, which helps 100%. So it's equal parts pain science, the words we use. There is kind of this art behind the science of how we use a needle, just the clinical skill, the clinical application, how we're using the needles. And then lastly, it is the reinforcement, or what are we doing immediately after the needle. So kind of these three little teaser topics that I want to target for today's presentation of dry needling doesn't have to suck. And again, that means we're acknowledging that sometimes needling can suck, depending on how we apply the needle, depending on what's going on with the patient, depending on what we do afterwards. And again, this is not targeting any methodology out there. I'm thinking back to when I first started needling myself in the clinic. I was initially trained kind of dually radiculopathic but trigger point model. But as I look back at how I use needling in the clinic, it was fairly trigger point based. My whole explanation was you have these taut bands. I'm going to go in, piston this needle, cause a little twitchy cramp response. And that is this trigger point deactivating. That is that band of muscle kind of lengthening, deactivating itself. But that explanation and the rationale for needling was kind of immediately followed by almost an apology. It's like soreness is normal, 24 to 48 hours of soreness. After I get into upper trap, you're going to be pretty sore. And as I look back, here comes the pain science portion of it, is that I was almost apologetic for this treatment that I was going to offer them that I knew would help. I knew I could improve their mobility. I knew in the long run that post-treatment soreness wasn't worsening their pain or their condition, and ultimately their pain would come down, their function would improve. But I almost presented needling as man, this is a really effective treatment, but it's going to hurt for the next day or two. And again, that was me. So the pain science of the words we use and how we present it, this is by no means saying you shouldn't give true informed consent. You shouldn't thoroughly explain the procedure. It is an invasive procedure. We're using needles. It's probably the only invasive procedure we as therapists are using in the clinic. So we have to give it that extra respect, that extra acknowledgement, and legally that consent. But I guess the first encouragement I want to give you is to be a little less apologetic about how uncomfortable this treatment's going to be or how sore they might be for the next 24 to 48 hours. Everything I touch on next is, really that 24 to 48 hours of soreness that I used to prepare patients for. These days it's, okay, yeah, there might be some lingering soreness, but it's not going to be that bad. It's not going to last 24 hours. So again, maybe that's just me anecdotally changing how I use a needle, or me more confidently having reps and being that expert that can tell you, the soreness is not going to be that bad. I know it's a needle. Like, let's talk about if that brings any anxiety to you, but I'm much less apologetic. And initially it is just the words I use. And that goes into all of the level 1 questions we get of like, what's your little 3-second script before you put a needle in? Or what words do you use? How do you present needling to a patient? And at this point, I just have the script of achy, crampy, sore is normal. A twitch is a good sign. It might not be entirely comfortable, but it's not going to be that bad. And really, it's those words and that confidence to say, I know that it is a needle and it's not going to be complete confidence, but it's not going to be that bad. The soreness won't be extreme. It won't last long. And everything that we're going to do, exercise, loading, even other manual techniques, is going to mitigate that soreness. Like, this is going to help. This is going to make you feel better. That's why I think it's worth a try. So that's point 1, is just pain science. The words we use really frames to our patients how much anxiety they have. Or, 100%, if you just prepare them for 24 to 48 hours of soreness with your introduction to dry needling in the clinic, they're probably going to have 24 to 48 hours of soreness. Good news, bad news. They'll come in and be like, yeah, you hit me hard. Like, I felt my trap for the 2 days. And there's a spectrum there on how we deliver the needle that needs to be appreciated. That's point 2. Again, just looking back to myself in the clinic, how I use the needles, relatively trigger point based. The twitch response was the therapeutic intent. That was the whole rationale to why and how I was using a needle. And that was a more mechanically aggressive approach to needling, which does disrupt tissue. It does cause this micro-inflammatory response, and there is soreness involved. Again, I hit a lot of upper traps and gastrocs and deltoids when I first started needling. And it came with that initial, like, sorry, you're going to be sore for 1 to 2 days. And then it almost immediately is like me running to get a hot pack in the clinic of like, okay, let's, I really don't want you to walk out. Like, I want you to come back. I don't want you to walk out of here more sore than you came in. And that's kind of the juggling act that I did for the first few years that I started needling. How we use the needle is important. And again, different educational institutions, different ways to use a needle. A very aggressive mechanical pistoning. We're still there. Okay, gave me a little paused thing on Instagram. It's probably obvious to say, we're still live here, good. The more pistoning, the more mechanical disruption of tissue you do, the more sore they'll be. And sometimes on that extreme end, that's the intent. We want to disrupt tissue. That's collagen resynthesis. That's a proliferative response. It's an inflammatory, kind of an intentional micro-inflammation that the body will then heal. But we have to acknowledge that we can make someone pretty sore, whether that's our intent or not. If I'm in there pistoning tissue, 1 twitch, 2 twitch, 5 to 10 twitches later in upper trap, at that point, we should say, you're going to be pretty sore. Like, there's a dose to needling. That's going to be a topic of a future PT on Ice. The dose to needling is how deep, how quickly, how many pistons, how many needles, but also what are we doing immediately after? So when I say that I'm much different now with how I apply the needle for dry needling, it is because of it's how I was trained in the research we had at the time. I still see value in that twitch response. I personally don't see value in 10 twitch responses. There's research to support that, but that's just myself as a clinical expert saying, the pendulum that I've been riding in my career is that there's kind of that least effective dose, or what's the number of pistons, number of twitches that gives me the best bang for my buck without causing soreness to my patient. The other side of it is e-stim. And really the main research I want to present to you today is that, and again, it's a common question. Group A, we're just going to go in, use needles, get twitch responses. Group B, whether we get twitch responses or not, we're going to use e-stim, which is more effective, first of all. And I have two pieces of research that I can unpack for you. First of all, chronic low back pain. Group A, they went in, you can see the body chart in the publication, but they basically hit the paraspinals, so L3, L4, L5, and then glutes, glute max, glute med. And they used e-stim, low frequency e-stim for 10 to 15 minutes. Chronic low back pain, that's Group A. Group B, they went in and had the more, the non-e-stim, but the more, the pistoning, the more trigger point based approach. If they went in and hit QL, glute, the erectors, but just pistoning, looking for a twitch response, not using e-stim. And actually, the singular publication said both groups improved. That's cool. Function improved, pain scales went down. People were happy in general. But what this publication group also acknowledged is that, plus or minus, if you look at the outcomes, they were pretty similar. But what they noticed is that there was a high rate of abandonment in the needle-only group, in the pistoning group. And again, just the clinical expertise of, I think that's pretty realistic. If you are not using e-stim, if you're aggressively pistoning tissue targets, even if we're saying there's research that supports that approach and their pain might go down, their function might go up, we just have to acknowledge that some patients aren't going to come back. And that's exactly what this research found. So the e-stim, I would say in that sense, outperformed needles only. Similar study design, but now we're in upper trap for neck pain. This is a Brazilian journal of PT, but Group A, they went in and got 5 twitch responses from upper trap and came out. They were done. Group B, they went in, got the same 5 twitch responses, then used e-stim. And actually pretty similar findings. Both groups did have an improvement in NDI, in side bending, in neck pain scores. The only difference between the groups was the 0 and 24-hour patient reported pain. So basically, the conclusion from this research was that post-needle soreness was less, 0 and 24 hours, when we use e-stim. They did say at 48 hours, the groups were the same. So that kind of feeds back to, we can cause some soreness with needling, but maybe it's even your intent, depending on how you're trained. It'll go away. 48 hours is kind of the cutoff of like, the soreness will decrease eventually. But again, kind of back to the start of all this of, at this point, when I'm needling patients, I don't prepare them for 48 hours of soreness. That's partially how I present the treatment, but it's also, I use more e-stim. And for now, I mean, there's a lot of e-stim and dry needling research I could unpack, but right now I'm just giving the 30,000 foot view and the endorsement that says, if you use a little e-stim, even if you're going after twitch responses, even if you're going after trigger points, quote unquote, if you use some e-stim, your patients will be less sore. Or that first publication, you could say there's going to be more patients coming back to your clinic. There's going to be a lower rate of abandonment if you use some e-stim. So we have the pain science aspect. We have how we use a needle. And lastly, it's the aftercare. It's the reinforcement, meaning what do you do immediately after the needle? Again, I picture myself early days of needling, no e-stim, hitting upper trap, gastroc, deltoid, glutes. And I was a little more joint-based back then. So I go into my joint-based manual therapy, which helps sometimes. But then, like I mentioned, then I'm running for my ice pack, my hot pack, like I'm apologizing to the patient. Like I want them to walk out of the door feeling better, not worse. When I made one switch, and this isn't even using e-stim, when I made one switch in my treatment planning, I saw that number drop in half. And like I said, it wasn't how I use the needle. That one switch that I made was After I used my needles, that patient is complaining about, woof, yeah, you got upper trap is pretty sore. I see what you're saying. The one switch I made was, instead of running for the hot pack, I said, well, yeah, I mean, upper trap is a very reactive tissue. Like, that's kind of the soreness I was telling you about. Like, it's expected, it'll go away 24 to 48 hours. But the one switch I made was, I only have like 2 to 3 exercises planned. If we could go in the gym and do those now, then 100% will come back. I'll get an ice pack, hot pack, whatever you need. But if we could get through this like 15 to 20 minutes of loading of exercise first, I'd like to do that right after the needles. I know you're sore, but sometimes this actually makes it feel better. And that one switch, like I said, it did drop how many patients were walking out the door at the end of that session still saying like, ooh, yeah, I don't know, this needling it's pretty intense. Like, I trust you, it's helpful, but it's pretty intense. Just by doing something loaded, something active immediately after the needles, 50% is just like the ballpark figure of like, patients would still say like, yeah, okay, I'll use a hot pack later if I need to, or I'll use ice. But with that one, just like, not even saying you can't have a thermal modality, but me saying, let's do some movement, some activation, some loading first, that soreness goes away quickly. We have one little nugget of research that did something similar. They were dry needling infraspinatus. So again, no e-stim. They went in, got their twitches, infraspinatus, which can be a gnarly spot. Can refer to the front of the shoulder, can refer down the arm. But Group A, they went and they did nothing. Well, they had 3 groups actually. Group A, they used a ultrasound machine that wasn't plugged in. So your placebo of like, oh yeah, here we go, let's make it feel better. Group B, they went out and did, just your generic TheraBand, like your eccentric external rotation TheraBand exercises. And I think they did a thermal modality as well with the ultrasound group. I'll have to look, but essentially they're saying, let's address the soreness on the table, more passive modalities, or just see what the natural course of it is, versus if we add load, if we add activation and exercise immediately after, is that better? Is it worse? Is it the same? What they found is immediately going into loading or activation or exercise after dry needling is that post-treatment soreness got better, which I think empirically a lot of us, if you're doing dry needling in the clinic, we see that. Like, if we go back to that upper trap, I love farmer's carries. I love load that just, there's weight and gravity trying to pull your shoulders down. All I want you to do is, whether it's shoulder stability, neck pain, like I love that light 50% recruitment of deltoid and upper trap. Like, let's just go walk around. I love that for upper trap. And again, I used to do thermal modalities. I used to do a lot of trap stretching afterwards for that soreness. Load, activation, exercise and excursion using the muscle or the tissue target that you treated will help. So really, those are the 3 main points I wanted to hit. And again, if you joined a little bit late, the kind of the angsty headline was dry needling doesn't have to suck. If that language is a little too harsh for you, I was just acknowledging that in the early days of when I was needling, I almost presented it as, yeah, soreness is normal. Like, you're going to be sore for 24 to 48 hours. And the 3 topics I covered that could almost immediately mitigate that is, first, the pain science of the words we use, how I presented it to the patient. If you say they're going to be sore for 24 to 48 hours, they're going to. So it's not that I lie to them and say it's going to be complete comfort, but I focus less on that as an immediate and an expected consequence. If they ask, is it going to hurt? Am I going to be sore? I say, sometimes soreness is expected. Like, I'm going into a muscle work, like we're treating dysfunctional tissue. So yeah, potentially there could be soreness. But at this point, I'm confident enough to say, depending on when the treatment is, like, it's not even going to last the rest of today. Like, I have a lot of stuff planned today. And really, I don't think you're going to be that sore even walking out the door. So it's kind of the words and the pain science. It's how we use a needle. And 30,000 foot recommendation today is just use some e-stim. There's lots of different ways we can use e-stim, frequencies, durations, different circuits. But if you use some e-stim compared to none, your patients will be less sore and there'll be a lower rate of abandonment. And the last endorsement is just activate, recruit, load. Your reinforcing exercise from dry needling should be less passive. I kept comparing it to thermal modalities like heat and ice, but less passive, more active. If you kind of focus on those three things, and I guess if you are a newer needler and patient experience or patient comfort is important for that aspect of the treatment of needling, focus on those three things and see if it helps. But again, my first time on here, thanks for joining. I'm going to start wrapping up. My name is Paul Kaloran. I'm one of the leads kind of launching the dry needling division with ICE. Crazy excited. This is going to be some of the most exciting dry needling education content out there. I've taught personally for 10 years. I've taken other educators, and there are some excellent educators out there. This will just be something completely different. And we're going to use a lot of e-stim, not just for mitigating soreness, but we're going to use e-stim in our courses in ICE dry needling, which we have both an upper and a lower course option, introductory. You can have taken courses or not. We're going to talk about how to use e-stim for pain relief, pain modulation, for athlete recovery, and for neuromuscular changes, for recruitment, for output, for improving neuromuscular function. All of that will be unpacked, specifically upper and lower quarter for those courses. We do have 4 courses before the end of the year. Starting in October, we have upper and lower. We're going to Oviedo, Florida, Hendersonville, Tennessee. We're going to Onward, Milwaukee, and Maryland. So if you're looking for a dry needling course end of this year, please join us. Be one of the first to jump on our ICE dry needling courses. I will be back on the show, but thank you for joining this morning. If you're catching this on the recording, thanks. And I'll be back. I'll see you guys soon. And if you have topics you'd like to cover on, like specifically dry needling topics for PT on ICE, let me know. All right, signing off. Thanks for joining, guys.